So APP, Advanced Practice Provider, live webinar, Nancy Vogler, AGPCNP-BC, Anemia and Thrombocytopenia Basics, June 19th, 2024. We have some bio information there, but we kind of like to talk about it this way for our presenters. So Nancy, welcome. We're really glad to have you here today.
Hi, I'm happy to be here too.
So let's see if we've got this right. AGPCNP-BC, graduated from UNC Wilmington, and you've worked in advertising before going to nursing school.
Yes.
And attended nursing school at UNC Chapel Hill, and you're getting your MSN at Duke.
I've already gotten it.
You got, oops, okay, so you got it. Check that box. Excellent.
2014.
Okay, a while ago. Sorry about that. Nancy worked as a bedside nurse in medical oncology and as a nurse practitioner in primary brain tumors and malignant hematology.
Mm-hmm.
Currently works as a nurse practitioner at UNC Easttown in the benign hematology clinic and lives in Durham with your husband, 2 sons, and cat.
Yes.
And what's one other thing we might know about you? Travel, hobby, interests, something along those lines.
I really like to hike. That's kind of my husband and I and friends have gone to lots of national parks, and we like hiking. I did break my ankle pretty bad about a year ago that some of y'all may know about. And I actually did my first hiking last week since breaking my ankle. So I'm really excited to be back doing that.
I'm sorry that happened. Glad you're back at it. Totally get the enthusiasm. We'll have to talk more sometime. My wife and I are big national parks enthusiasts and like to go to a lot of different parks.
My husband actually proposed to me at Death Valley. And a lot of people think that we must be big Clemson fans, and I have to explain, no, I mean the national park. So.
That is great. I love that. Well, let's go ahead. I mentioned Poll Everywhere. We try to make the first question a really easy one. Anemia is a problem of not having enough healthy red blood cells or hemoglobin to carry oxygen to the body's tissues, while thrombocytopenia is a condition that occurs when the platelet count in your blood is too low. And while folks are thinking about that, flash up our disclosures. And then here we go. You can go ahead, everyone in our audience, and get to that Poll Everywhere link, and then go ahead and just check true or false. I forgot to mention earlier, totally anonymous. You're not being graded on this. We don't know who's answering what. So we encourage you to make your best guess, or if you know with certainty, either way, go ahead and put in an answer. We're trending pretty heavily on the true, 100% true. How are they doing?
We're very smart.
We have a sharp audience always. So with that, anemia and thrombocytopenia basics, I'll turn it over to you.
All right. So like I said, I'm Nancy Vogler. I work at UNC Easttown in the benign hematology clinic. I've been there a couple of years. Before that, I was in malignant hematology for 6 years inpatient on what was Med E3, now Med Q. So lots of experience with anemia and thrombocytopenia basics. This is actually going to focus more on the benign issues with anemia and thrombocytopenia and other things you may think of other than oncology. All right, learning objectives are to list the basic types of anemia and thrombocytopenia, identify common causes of anemia and thrombocytopenia, and describe management strategies for patients with anemia and thrombocytopenia. So another couple of Poll Everywhere questions. So in men, anemia is defined as hemoglobin less than 13. Okay, and it looks like everybody says true, and that's true. We'll kind of get to a little bit more about that later. And then we'll go to another poll everywhere question that says, in women, anemia is defined as hemoglobin less than 11, sometimes 12, depending on age of the woman. So yes, that one's true as well. Okay, so what is anemia? Anemia is any decrease in the number of healthy red blood cells. And if you don't have enough red blood cells, then you're not getting enough oxygen-rich blood supply to your body, which is crucial for it functioning well. In adults, anemia is defined as a decrease in hemoglobin or hematocrit. In men, that's a hemoglobin less than 13, and in women, that's a hemoglobin less than 11 or 12. Pregnant women, a lot of times we let ride a little bit lower towards 11. Occasionally, the elderly anemia can be defined a little bit lower, but it's usually somewhere between 11 and 12. Each reference range for the lab is different, but these are kind of World Health Organization definitions. Okay, so there's many different ways to classify anemia. One of my favorites is really looking at the MCV, which is the mean cell volume or the actual size of your red blood cells. You can have very small red blood cells, which is considered microcytic anemia, and that is an MCV usually less than 80. That should kind of tip you off to iron deficiency anemia, thalassemias, which are kind of mutations in your actual hemoglobin molecule. You could have alpha thalassemia or beta thalassemia, and those kind of range in severity from really not being clinically significant at all to requiring blood transfusions. Normocytic anemia is where those red blood cells are kind of normal in size, or you can have kind of two different ways that you have anemia that are essentially canceling it out. So if you have some microcytic anemia and some macrocytic anemia in the automatic counter, it can look like normocytic anemia. But that is an MCV anywhere from about 80 to 100, 80 to 95. So somewhere in that range. Iron deficiency can cause this in some cases, especially if it is concurrent with B12 deficiency or folate deficiency. A lot of drug-induced anemias are normocytic anemia. Sometimes anemia caused by liver disease or hemolysis can be normocytic. Anemia related to thyroid disorders like hypothyroidism can a lot of times cause a normocytic anemia. And then anemia of chronic disease, anemia of chronic inflammation, a lot of times causes a normocytic anemia. Occasionally a microcytic anemia if there's something else like iron deficiency going on. And then macrocytic anemia is really when those red blood cells are really large and larger than normal. Sometimes it can also signify that your body's spitting out new kind of not mature red blood cells. But that is an MCV, a mean cell volume greater than 100. So this is a lot of times seen in B12 or folate deficiency, drug-induced anemias, liver disease, especially with cirrhosis or malnutrition related to alcoholism. Thyroid can sometimes cause a macrocytic anemia. And then myelodysplastic syndrome or MDS, which is a cancer, can also cause a macrocytic anemia. So that's kind of the first thing. After I look at your hemoglobin, the first thing I look at is how big are your red blood cells, and that kind of gives me an idea of, all right, what could we be looking at for the cause of the anemia? All right, so let's look at an anemia case study. This was a patient that I saw in my clinic, a 47-year-old African-American female with a past medical history of hypertension, diabetes, obesity, and vitamin D deficiency. She actually came as a referral to my clinic, but she presented initially to her primary care provider for an annual physical, was last seen in 2021 because it seemed like there for a while no one had been seen since 2019 because of COVID, complaining of fatigue, hot flashes, cold intolerance, exercise intolerance, some restless leg syndrome, especially with kind of leg cramps at night. Her weight had increased 3 pounds over the last kind of 3 years. Her vitals were stable. She was not having chest pain or shortness of breath. No real surgical history, certainly none recent. She was from Washington, D.C. She had moved to North Carolina in 2019 with her husband and children, drank alcohol socially, but nothing excessive, no tobacco, no illicit drug use. So her labs from 2019 looked pretty good. Her white blood cell count was normal at 11. Hemoglobin was normal, maybe on the low end of normal at 11.6. MCV was normal at 80. Red cell distribution width was normal. Platelets were 356. CMP, including her kidney function and liver function, was unremarkable. Thyroid testing was normal. Vitamin D was 38. Her A1C was 6. So another poll everywhere question. What do you think is causing her symptoms? This fatigue and exercise intolerance, hot flashes. So we have menopause as something that could cause some of these: thyroid disorder, iron deficiency anemia, B12 deficiency anemia. She was 47. All right. Still got people thinking about it. All right, it looks like about 56% of people are thinking iron deficiency anemia, about 25 with menopause, and about 13% with B12 deficiency. Those of you that guessed menopause and iron deficiency anemia, I think, are on the right track. B12 deficiency, certainly she had some restless leg and leg cramps. So let's see what her labs looked like at her recent visit. So her white blood cell count still normal at 8.9. Hemoglobin had dropped from kind of the mid-11s down to 9.7. The MCV had dropped to 71. RDW was slightly elevated at 18. Platelets were slightly elevated at 467. Thyroid was normal. I always like to make sure that's checked because thyroid a lot of times can cause similar symptoms to anemia. Her vitamin D was good at 41. Her A1C was still 6. Iron panel was completed. Iron was low at 22. Saturation was low at 9%. TIBC was elevated at 402. Ferritin was low at 11. B12 was 423, which is in the normal range. So this is definitely iron deficiency in her case. I think those of you that said menopause are not wrong. I think a lot of her symptoms could just be related to menopause as well. Some of that education I have to do with my patients that, you know, repleting your iron may help with some of your symptoms, but if it's something not related to your iron, of course, it's not going to help. All right, so what is the most common cause of anemia? Is it chemotherapy, drugs, or cancer in general, iron deficiency, B12 deficiency, or hemolysis? All right, looks like everyone thinks iron deficiency, and I think that you understand which way I'm trending right now. So you are right. Iron deficiency anemia is the most common cause of anemia worldwide. According to the World Health Organization, estimates in 2019 say that 40% of children under 5 are iron deficient, 37% of pregnant women, and 30% of women aged kind of 15 to 49, which is that pre-menopausal menstruating women, are anemic. When I first saw those numbers, I was pretty blown away by just how many women especially are iron deficient. I've seen studies that say it's anywhere from 1 in 5 to 1 in 6 women have iron deficiency anemia. Symptoms of iron deficiency anemia include fatigue, weakness, shortness of breath, especially with any kind of exertion, exercise intolerance, dizziness, or even passing out, racing heart and palpitations, or even kind of feeling of anxiety, chest pain, hair loss. I see a lot of women that was their reason that they kind of got medical care was hair loss. They're just losing lots and lots of hair, brittle nails, restless leg, and pica. And pica kind of most commonly, pica is where you essentially crave things that don't have any nutritional value. The most common thing that I see women or men craving is ice. I have people that eat cooler full of ice a day, or have their own personal ice makers at home and just are eating it all the time. But I've also seen a little bit of everything: dirt, chalk, clay, paper. I've seen people that eat Smarties or gumballs, anything kind of crunchy and chewy. So anytime you're craving anything unusual like that, think that it could be iron deficiency. Usually you replete the iron and that goes away fairly quickly. All right, so what defines iron deficiency? Pretty much a universally accepted lab value for iron deficiency is the iron saturation, definitely under 15%. Some places you'll see under 20%, and a ferritin under 30. That's most insurances will cover iron infusions for ferritin under 30. I usually get both the iron saturation and the ferritin though, because lots of things can increase your ferritin. It's an acute phase reactant, so any kind of acute or chronic inflammation is going to increase that. So sometimes you need both the iron saturation and the ferritin to kind of determine, is it true iron deficiency? Most of the time your iron binding capacity will also be elevated. Your receptors are all out, ready to accept iron, but there's just nothing there to do to fill those receptors. So I kind of think of, there's always 3 different causes of iron deficiency anemia, or 3 different buckets that I think of. Initially, and I usually go through this with all my patients to try and figure out why they're iron deficient. decreased dietary iron intake. So the first thing I talk about with my patients is their diet. Do they eat meat? What kind of meat are they eating, and how often? Are they vegetarian? Are they vegan? Are they eating any leafy greens or fruits? Heme iron, or iron that is from meat or animal products, is our number one absorbable source of iron, with red meat kind of being at the top of that pyramid. So red meat, any kind of beef, I like to see that folks are eating at least weekly or a couple of times a week. Liver or any kind of organ meat also have pretty much the same amount of iron as beef. So if you have someone that likes to eat liver, kidney, or any kind of organ meat, that's encouraged. Chicken, pork, fish, shellfish are a pretty decent source of iron. So I generally recommend that if you're not vegan or vegetarian, that you eat, and you're iron deficient, you eat some sort of meat every day, and then red meat once or twice a week if your cholesterol can handle that. With my vegetarian and vegan folks, I generally think they need to be on a multivitamin with iron at baseline, just to make sure they're getting the B12 and the iron that they may not be getting with the vegetarian diet. There are some vegetable sources of iron: dark leafy greens, beans, lentils, dried fruit is a pretty good source of iron. Iron fortified cereals and pastas are a really easy way for folks to get a fair amount of iron. But again, those aren't as absorbed quite as well. If you have a vegetarian diet, there's some thought that eating kind of salad with something with vitamin C on it, or any of your vegetable sources of iron with a vitamin C containing food will help you absorb it better. There are folks that have decreased iron absorption that causes iron deficiency anemia. That's typically my gastric bypass patients. The folks that have had a Roux-en-Y are almost always going to be the ones that have the most decreased iron absorption and iron and absorption of any kind of vitamins and trace minerals. But I have definitely seen iron deficiency in folks that have just had a sleeve gastrectomy or have had a duodenal switch. So anytime you're having a malabsorptive surgery, or if you've had a gastrectomy for any kind of reason, or part of your colon removed, then you may have some decreased iron absorption. Crohn's disease and ulcerative colitis a lot of times can cause you to not only have decreased iron absorption, but also have kind of slow bleeding that can lead to iron deficiency. Occasionally I'll get a young person that has iron deficiency of unknown reason. We'll get a GI workup and do a colonoscopy, and we'll diagnose a Crohn's disease or an ulcerative colitis. Folks with celiac disease also have some decreased iron absorption sometimes. So I always ask about, do you think you ever may have gluten intolerance? How do you feel after you eat a large meal full of carbs? Do you get bloating or diarrhea or abdominal pain? And I'll start with kind of serum testing for celiac disease. I've diagnosed a handful of these, usually in a young person as well, and have to work closely with GI for these diagnoses. Blood loss is by far the number one reason I see that folks have iron deficiency anemia, with menstrual bleeding being the highest. You really, I kind of get into the nitty gritty of what menstrual bleeding looks like for each woman, how many pads or tampons they're going through, how long are they bleeding, has it changed any recently, or is this what you've always done? And then work closely with GI to help get that under control, because with any kind of blood loss anemia, if you don't fix the source of the blood loss, then you're just going to be stuck in this cycle of iron infusions and iron supplements and just not making any progress. Chronic GI bleeding, a lot of times that's ulcers or venous malformations that are causing bleeding. I have a few folks that their only blood loss is through hemorrhoids. So if you have hemorrhoids that bleed enough or frequently enough, you can certainly become anemic with that. And then I have a handful of people that have been sent by their primary care providers, and you get into your history and you realize that they are regular blood donors. These are some of my hardest patients because my recommendation is to stop blood donation, and most of the time folks are doing it because they feel like they're giving back. So you just kind of have to say, all right, if this is causing you to be anemic and have these symptoms, then it's something that you need to think about doing or about stopping. Occasionally I'll have folks say, you know, a year ago they wouldn't let me donate one cycle because I was anemic, and I'm like, that's a red flag there. So always ask about blood donation. A lot of times people don't even put two and two together until you say, yeah, that's blood loss there that you're doing regularly. But those are kind of the three buckets that I put into when trying to figure out why they're iron deficient. Is it through they're not taking in enough iron, they're not absorbing enough iron, or are they losing too much blood? All right, and so treatment of iron deficiency. The first thing that we always want to make sure is done is that oral iron is being given. And these are approximate recommended intake of iron, because I think the actual recommended is like 8, 18, and 26 or something, but I can best remember it in multiples of 9. So men and women that don't have menstrual bleeding, whether that's because they've had a hysterectomy or postmenopausal or have an IUD in place, need 9 milligrams of iron every day. Women that are having menstrual bleeding need 18 milligrams of iron a day, and that's typically what is in your multivitamin with iron, like a women's multivitamin with iron. And then pregnant women need 27 milligrams of iron a day at least, and that is typically what is in your prenatal vitamin as well. When you are to the point of iron deficiency or anemia, of course, you need a little bit more than that. For some reason, you're not able to kind of make up for it in your diet. So oral iron supplements are what I recommend first. And I generally start with just plain all-ferrous sulfate, which is very cheap, over the counter. Most recent studies have shown that every other day dosing is adequate enough to increase your hemoglobin and your iron stores. We used to give it up to 3 times a day, but that really can cause a lot of GI upset, nausea, vomiting, horrible constipation. So really every other day has been shown to be just as effective, and certainly a lot less GI side effects than even daily or twice a day, 3 times a day. With that being said, it still may need to be individualized for each patient. Some people can't tolerate ferrous sulfate. It's an immediate release iron, and it can also be pretty rough on the stomach. So I tell people it will say to take it without food, but if you can't tolerate it, then try it with food. If that doesn't work and you're still nauseous, then try one of the coated irons like Slow Fe or any of the slow release irons. Those are a lot of times better tolerated. And then there's other formulations like a polyiron complex called Ferrex. That's a capsule that I have to recommend to a lot of my pregnant women with nausea. That is better tolerated. So you may just kind of need to figure out what iron works for patients. And then some patients aren't able to tolerate dedicated iron supplements. So those are the folks I do recommend a prenatal vitamin or a multivitamin with iron or a gummy iron that just has 9 milligrams of iron in it, because any iron is going to be better than nothing there. Some folks still, for whatever reason, if they don't tolerate oral iron or if they don't absorb oral iron, like our Crohn's disease patients or gastric bypass patients, still need iron infusions. A lot of times you can just refer to hematology for that. It's kind of like a menu of iron infusions to choose from based on insurance coverage and the risk-benefit profile of each iron infusion. All IV irons have a risk of allergic reaction that can kind of run the gamut from facial flushing to itching and hives to anaphylaxis, which can be difficulty, which can, of course, be life-threatening, depending on what I feel like the patient's risk of reaction is. We can do a lot of iron infusions kind of out in our satellite infusion centers, but if I think they're going to have a high risk of infusion reaction, then they get the infusion in the cancer hospital at UNC Maine. And then we also do iron infusions for our pregnant women that need it, that are just not able to keep up with their iron needs. We only give IV iron in second and third trimester, and that generally does need a hematology referral as well. You can give packed red blood cells for iron deficiency anemia treatment. I typically reserve these for symptomatic patients with a hemoglobin under 7, but also know that these folks are also going to need an iron infusion. When you look at packed red blood cells, it only has about 300 milligrams of iron per unit, where with an iron infusion, we can give up to 3,000 milligrams of iron in a bag. Most people that are severely anemic, their iron deficit is going to be somewhere between 2,000 and 3,000 milligrams. So a blood transfusion is good if you're symptomatic to kind of bridge you to iron infusion, but not always my first choice. And these women that are, I say especially women they're iron deficient from menstrual bleeding, I'll have people hit my office with a hemoglobin of 4 and they're walking and talking and say they're just a little bit tired and, not able to exercise, things that you think kind of wouldn't be compatible with life. But if you are losing a little bit of iron each month through menstrual bleeding, it's kind of like a slow burn down. These women can really tolerate very low hemoglobin levels before they kind of get to medical attention and decide, all right, something needs to be done about it. Those folks need an iron infusion because they're just so behind that it would take a year or two of oral iron supplements to kind of make up for it. All right, so let's move on to B12 deficiency anemia. So vitamin B12 deficiency is another vitamin that is crucial to normal blood cell formation and neurologic function. Symptoms include typical anemia symptoms, but also can include weakness, symmetric paresthesias, gait changes, brain fog, glossitis, so these big beefy red tongues, and oral ulcers. Some folks have pernicious anemia, which is where autoantibodies interfere with B12 absorption. This is most common in kind of Caucasian, white people from Northern Europe. And they do have an increased risk for GI cancers and autoimmune diseases. So if you suspect pernicious anemia, then you certainly need to get them to GI for further evaluation and monitoring. So B12 deficiency can be caused due to decreased dietary B12 intake. So B12 is in a lot of the same foods that iron is in, so liver, meat, fish, but it's also in dairy products and eggs, and is in a lot of fortified cereals. There are some population that has decreased B12 absorption. So that's folks that have had bariatric surgery or gastric bypass, any kind of gastric or ileal surgeries, Crohn's disease, celiac disease, and just gastric atrophy with aging can sometimes cause B12, decreased B12 absorption. So make sure you're checking these in your elderly population as well. And then some medications block B12 absorption. So that's metformin, H2 blockers, and PPIs. So folks that have been on these long term, you just kind of need to keep an eye on their B12, especially if they start to become anemic. There's many routes to B12 repletion. Unless it's someone that has kind of decreased B12 absorption through bariatric surgery or Crohn's disease, I start with oral or sublingual supplements. They're available over the counter, and usually in about 2,000 micrograms a day dosing. Occasionally, folks will need injections that can either be done in clinic as a nurse visit or home injections, and that's just kind of depending on your insurance coverage. So it's a weekly injection for a month, and then monthly injections usually hold them. Occasionally you'll have intranasal or skin patch for B12 deficiency. I don't like these because the absorption is kind of variable. It's expensive and a lot of times not preferred or not covered by insurance companies. So. There are other vitamin deficiencies that cause anemia. That's folate deficiency, copper deficiency, and vitamin C. Vitamin C doesn't actually cause anemia, but it can help with the absorption of iron. So a lot of iron supplements also include vitamin C. Folate deficiency, you certainly need in pregnancy. You need to give folks folate deficiency if they have chronic or acute hemolytic anemia. Gastric bypass patients a lot of times don't absorb folic acid. Your folks that have excessive alcohol use a lot of times need additional folate. And folks that are on methotrexate, be that the cancer patient on methotrexate or the rheumatoid arthritis patient on kind of low dose methotrexate. We generally replete with 1 to 2 grams daily of folate. Copper deficiency is important in the copper is important in the formation of hemoglobin. A lot of times malnutrition, malabsorption can cause this, or folks that are taking a whole lot of zinc supplements. So you do have some folks that are taking zinc for healing or kind of to prevent getting sick and make themselves copper deficient. So when I check copper, I usually check zinc as well. Replete generally with oral supplement daily, but if they're having copper deficiency can cause neurologic changes. So if they're having any neurologic changes, then they may need IV copper. Hemolytic anemia. So hemolytic anemia is another type of anemia. A lot of times this is a normocytic anemia. And that's where red blood cells are destroyed faster than they can be replaced. And depending on the cause or the onset, it can be life-threatening. So a lot of times these require hospitalizations. Causes of hemolytic anemia can include an autoimmune process. Thalassemias can sometimes cause baseline mild hemolytic anemia, sickle cell disease, G6PD deficiency, especially if they're deficient and have gotten a medicine that can cause hemolytic anemia. You have hemolytic transfusion reactions that can either be acute or delayed a few days, that can be life-threatening. TMAs, which we'll discuss a little bit later. There's mechanical hemolysis that I've seen with prosthetic heart valves that can also be caused by aortic stenosis, where just the shear from the valve or the stenosis is causing destruction of your red blood cells. And that generally requires cardiology's input to a lot of times replace the heart valve is the treatment for that. There is mechanical hemolysis called heel strike hemolysis, which we see in marathon runners that kind of pound the pavement for long periods of time. Bongo drumming hemolysis is the same theory, where you're strumming your hands and causing hemolysis that way. Liver disease can cause hemolytic anemia. And you want to suspect hemolytic anemia when you have someone with kind of acute anemia, and then markers of hemolysis, which are an increased reticulocyte count, very increased usually, an increased LDH, a low, nearly undetectable haptoglobin, an increased bilirubin, and then when you see schistocytes or spherocytes on your smear. Usually it's a positive direct Coombs test, not always though. Exam findings, these folks sometimes will be jaundice from their elevated bilirubin, have dark urine, and a lot of times will have a large spleen as well. This chart is basically just to let you know that there's lots of reasons you can have drug-induced anemia. So you can get iron deficiency if you're having GI bleeding from aspirin or NSAIDs or steroids. So it's important that folks are on something to prevent ulcers if they're on one of these things. B12 deficiency, again, can be caused by PPIs or H2 receptor blockers, too many antacids, metformin. Folate deficiency would be methotrexate, some antibiotics, and some anti-seizure medicines. There's a whole slew of medicines that can cause hemolysis, and then also ones that can cause impaired or suppressed bone marrow function, including chemotherapy drugs. Oops. All right. So iron deficiency anemia in postmenopausal women or men should be considered this until proven otherwise. All right, I think everyone thinks colon cancer, and that makes me so happy. Oh, we got a little bit of iron deficiency anemia. All right, so let's go on to the next slide and we'll figure this out. So anemia in a postmenopausal woman or man is evidence of colon cancer until proven otherwise. This population should not be bleeding. The most common cause of anemia is bleeding. So you need to make sure they don't have a big tumor or polyp that's bleeding, causing colon cancer. So any kind of new anemia in a postmenopausal woman or a man needs to have a colonoscopy, especially if they're over 45. They should already be having colon cancer screening. Occasionally, anemia is the presenting factor for MDS or multiple myeloma. That is typically adults older than 50. You have a normocytic or a macrocytic anemia. You have an elevated red cell distribution width, a low reticulocyte count, and no known bleeding. Sometimes with MDS, you have other cytopenias, including thrombocytopenia and neutropenia. And with multiple myeloma, a lot of times you'll have bone pain, increased serum protein, creatinine, or increased serum calcium. So those always need to be in the back of your head, especially for the over 50 population. Okay, we're going to actually hold our questions for anemia until the end and move on to thrombocytopenia. All right. Pull everywhere. A platelet count of 110 is considered mild thrombocytopenia, moderate thrombocytopenia, or severe thrombocytopenia. Okay, we got most people thinking mild, and it is mild. A platelet count of 40 is considered mild, moderate, or severe. Okay, we're split kind of close to 50-50 with moderate and severe, and it is considered, that's a severe thrombocytopenia. Oops. All right, so thrombocytopenia is defined as any platelet count below 150. Mild is 100 to 150, moderate is 50 to 100, and severe is less than 50. And even in some diseases like immune thrombocytopenia, we don't consider severe thrombocytopenia until it's under about 20 or 30,000 in that case. Folks that are at risk for spontaneous bleeding without any kind of injury or trauma typically have a platelet count less than 10,000 to 20,000. All right, so there are lots of things that can cause thrombocytopenia. We're going to go over some of these. So in about 2.5% of people, it's normal to have a platelet count less than 150. This is just your bell curve principle. Vitamin deficiencies, similar to the ones that can cause anemia, can also cause thrombocytopenia. So that's B12, folate, and copper deficiencies. Liver disease or cirrhosis, either non-alcoholic or alcoholic cirrhosis, can cause thrombocytopenia. Immune thrombocytopenia and TMAs, which are thrombotic microangiopathies, such as TTP, can cause thrombocytopenia. I put them red because that can be a life-threatening event. Viral illnesses or bacterial illnesses or parasites can cause low platelet count, including tick-borne infections, which we're seeing more of this time of year. And then cancers can cause thrombocytopenia, both hematologic and non-hematologic. You can certainly see severe thrombocytopenia in AML, which is a emergency as well. And then acute illness and sepsis is also another really common reason for having low platelet count. I think I'm going to skip this case study because we're starting to run a little bit low on time. And we'll just get to some more information about thrombocytopenia. So immune thrombocytopenia, or ITP, used to be called idiopathic thrombocytopenia purpura, so you'll see it both ways, is an isolated thrombocytopenia that results from essentially accelerated clearance and destruction of antibody-coated platelets. So it's an autoimmune process where you're really just destroying your own platelets. And I stress that this is an isolated thrombocytopenia. So if you have somebody that has, other cell lines that are low, it's most likely not ITP. Symptoms of ITP are fatigue and headaches occasionally, definitely bruising, and mucosal bleeding. So that's nose bleeding, gum bleeding, or vaginal bleeding if it's a woman, worsening vaginal bleeding. Wet purpura, which are essentially like blood blisters in your mouth, and petechial rashes, which are like purple dots on your legs. A lot of times with ITP, you don't see kind of large volume blood loss like GI bleeding. It's really more like the mucosa bleeding. In primary ITP, you have no known cause. It really is idiopathic. There are some other causes of ITP that you can kind of suss out, and that's infection. That's hepatitis C, HIV, occasionally H. pylori, or autoimmune diseases. It'll a lot of times go hand in hand with autoimmune diseases like lupus or rheumatoid arthritis, in the same principle that if you have one autoimmune disease, you're more likely to get another one. Treatment of ITP, we treat if you're actively bleeding or at a significant risk for bleeding. If your platelet count is less than 20 to 30,000, or in pregnancy, especially in the third trimester, and you're, wanting to have a epidural or have a C-section planned, we want kind of your platelet count above 50 to 75 in that case. The treatment of ITP is a little bit different because if you give these folks platelets, they're just going to eat them right up and it'll be a waste of a bag of platelets. What you need to do is really tamp down the immune system. And so you start with steroids. That's typically high dose Decadron for 4 days. Occasionally you'll do daily prednisone as if that doesn't work, or if they have contraindication for dexamethasone like pregnancy. You can give IVIG, which kind of works as a Band-Aid to quickly increase the platelets, but kind of won't do anything long term. A lot of times to get a more long-term remission and normalization of platelet counts, then you need rituximab. That's an anti-CD20 drug that is an infusion that we give twice, each infusion 2 weeks apart. And then some people still need medicine beyond that, and we have things called thrombopoietin receptor agonists, and that's romoclostim or Nplate, which is an injection that you give weekly, or pills that you can take. That's eltrombopag, which is Promacta, or avatrombopag, which is Doptelet. All of those are generally easily approved for treatment of steroid refractory ITP. Occasionally, folks will need a splenectomy. That used to kind of be our second line treatment, but with the invention of the rituximab and the L-trombopag and romiplostim, that has really kind of fallen by the wayside because you run the risk of a major surgery, and then if you have your spleen out, you kind of have long-term infection risks. And then I always like to ensure that patients with ITP have steroid prescription for travel in case they're, in a foreign country and don't have access to a lab and start bleeding. That can be a life-threatening event, and it's a simple fix with just 4 days of steroids. Liver disease can also definitely cause thrombocytopenia. It's been reported in 70% of patients with cirrhosis and 76% of patients with chronic liver disease. So something to keep in mind with your folks that have either diagnosed or undiagnosed liver disease. If you start to see thrombocytopenia, it's definitely part of the workup for thrombocytopenia to make sure you've ruled out any kind of liver disease. And then management of thrombocytopenia and liver disease, the greatest bleeding risk really is platelet count less than 60. You want to do a complete abdominal ultrasound to evaluate both the liver and the spleen to make sure you don't have this huge spleen that's sequestering the platelets as well. You want to do LFTs and hepatitis testing, and then referral to hepatology for further workup and management. TMAs are a pathological state where vessels are occluded by thrombi, leading to thrombocytopenia and microangiopathic hemolytic anemia. This can be systemic or just intrarenal. Both can lead to end organ damage. These diseases include TTP, atypical HUS or hemolytic uremic syndrome, Shiga toxin producing bacteria leading to HUS, which happens a lot of times in children. So we'll talk a little tiny bit about TTP, which is a TMA. It's a systemic TMA that leads to end organ damage due to a severe deficiency in Adams TS13, which is an enzyme that cleaves von Willebrand factor, which helps you, keeps you from clotting. Large von Willebrand factor leads to platelet adhesion, aggregation, and formation of these microvascular thrombi. Many organ systems can be affected, so the symptoms can be kind of wide ranging. You can have headache and confusion and stroke and seizures. You can have cardiac ischemia if it's affecting your cardiovascular system. Mesenteric ischemia with abdominal pain, nausea, vomiting if it's affecting your GI system, and then acute kidney injury if it's affecting your kidneys, which is less common in TTP. TTP is a medical emergency. The mortality rate is up to 90% without treatment, and that's where it was before invention of plasma exchange, but the treatment now is kind of rapid plasma exchange to remove these autoantibodies and replace the Adams TS13. We give steroids and rituximab, and then there's an injection called caplacizumab now that can kind of help maintain your platelet count. So these folks, it's not so much of a high mortality disease as it was, 50 years ago. So, and then infections can also cause thrombocytopenia. Viral illnesses such as hepatitis, HIV, COVID occasionally, EBV, flu, bacterial illnesses such as tick-borne diseases and H. pylori. So testing for H. pylori is important if you have someone with nausea and abdominal pain and thrombocytopenia. Mild thrombocytopenia often accompanies lymphopenia, and bleeding is rare if it's an infectious cause, and really treating of the underlying infection is key. Here are my references, and then we'll take a few questions. I think I saw one in the chat.
All right. Yes, if you'd like to take that one first, and then I'll go ahead and put another one up after that. Thank you so much.
If a patient has a low platelet count, it seems like a severe platelet count less than 50, due to splenic sequestration from splenomegaly from cirrhosis, do they still carry the same high risk of spontaneous bleeding, or is it different with splenic sequestration? I have noticed that my folks with liver disease don't have as much of a risk of bleeding. I don't have statistics for that. You know, my folks with liver disease sometimes can ride in the 30s and 40s without having bleeding. You kind of want to take into account, are they on any other medicines that could cause bleeding as well, like aspirin or an anticoagulation. You know, if you have splenic sequestration of your platelets, you know, your platelets are not out in the circulation, they're in your spleen. So you're still not going to have, still not going to clot as well. You're going to bleed longer. But I don't see those folks kind of have massive GI bleeds or anything like that.
All right. Thank you so much. And then another question, and so they're asking, why are patients with thrombocytopenia told not to be sexually active? Is that in fact a standard practice? And if so, why? I
do not tell my patients with thrombocytopenia to not be sexually active.
So maybe that's something that had been heard from another clinician, so we don't have an answer to that.
Yeah, I know folks that are neutropenic sometimes are told that.
Okay.
But I don't tell my patients with thrombocytopenia, as long as they're not actively bleeding.
Gotcha. Thank you. Well, thank you for taking those questions, and we are a little over the hour, so I'm going to go ahead and no, don't be sorry. You provided a wealth of information. Thank you so much. I'll do a quick wrap up, and then we'll move on. But we want to say thank you to the University Cancer Research Fund through the state of North Carolina for the funding, and the UNC Lineberger Cancer Network, or Cancer Center, Comprehensive Cancer Center. We want to say thank you to Benny Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, Lindsay Reich, and Barbara Walsh. Each one of them plays a part in each of these lectures, and we really, really appreciate all the hard work that is done to make these possible.